Musculoskeletal trauma, including non-traumatic fractures. Again, we go to decap deformities, evisceration of bowel through the abdominal wall, contusions, abrasions, avulsions, penetrations, burns, lacerations, tenderness, swelling. Here we have fractures. This would cause this type of deformities and angulations that we're looking for. Remember that bone, although it doesn't have potentially arteries and veins, it does have a blood supply through the bone, and bones can bleed. And so we're going to have to control the bleeding there. If there's an extremity that has been amputated, we also want to make sure that we provide some type of assessment and medical treatment for the dismembered limb. Although we don't have ice extremely readily available and a container to maintain its cooling, we definitely want to bring the limb with us if we think that there is a chance that we can have the limb reattached. So as far as the musculoskeletal system, it's used for our mobility. It provides for protection. Most of this is for conscious movement. It keeps us moving upright, allows us to stand, sit, run, and walk. It's allowed by mobility by our muscles which are attached to bone. Our muscles then are attached by tendons, and the bones to bones, they form up articulations or joints, and these are attached by ligaments. Our joints allow for our mobility, and we have many different types. We have hinge joints, ball and sockets. These kind of joints allow for different mobility. And in between those joints, we also have an area of or space where we have synovial fluid. This fluid allows and provides cushions to allow those joints to move freely and to allow us to have ability to absorb these types of shocks from running, jumping. Here we show you the entire skeleton. The axial skeleton is the head and spinal cord. The appendicular skeleton includes the thoracic cage, the pelvic girdle. Attached to the thoracic cage, we have the upper extremity, the humerus, radial ulna. We have the carpal bones and phalanges. As we look at the pelvic girdle, we have the femur, the patella, and to the front bone is the tibia, far behind fibula. We have the calcaneus, which is the heel, the tarsal bones, and phalanges. Here they're just showing us a little better picture of and isolating the upper extremity bones to include the scapula this time, as well as the clavicles and the lower extremity bones here. Showing you parts of the femur and the hip joint, the acetabulum, the ischium as part of the pelvic girdle, the ilium, which makes up the iliac and forms up towards the iliac crest. So here's an X-ray of a fracture. So it's showing us a forearm fracture. It's a fracture of the radial and ulnar bone. Looks like a small patient, pediatric, and so we're going to try to immobilize this as far as our treatment. We want to immobilize the joints above and below, so distally and most posteriorly, or inferiorly and superiorly. We want to immobilize the joints above and below. That would be our wrist bones, as well as the elbow bones when we splint. And we use a minimum of 4 ties. Never placing a tie over a joint, and never placing the tie directly putting pressure over the fractured site. So we remove the X-ray and we see this fractured extremity. It's going to be in a lot of pain because these bone ends do cause the ends to penetrate through muscles and tissue. And as they penetrate through muscle and tissue, the muscles tends to excuse me, spasm and contract. What we want to evaluate is the distal parameters, your CMS or PMS. Pulse, motor, and sensory, circulation, motor, and sensitivity. And this is distal to the fracture or injured site. Here's a slide depicting different types of fractures. There we see comminuted, where it's just pretty much disintegrated. We have one that's impacted, where the bone has kind of gone into each self or each end. Green stick fracture is more like a green stick. It's caused some splintering, but it didn't really break entirely through the bone. Oblique, spiral, and transverse, their description of just a type of line that they created. So oblique, that diagonally slashed line, the spiral where it rotated around the bone, and transverse that cut it straight across. Here we have the dislocation of the knee joint. Looks like the patella as well as the femoral head and the tibia and fibula are now not in the same space that they should share. They're not articulating anymore, they're not touching it, and they won't flex. This probably is locked in that position. We want to check our distal parameters. We would try to splint this in the position of comfort, or try to straighten and align it if there's no pulse, motor and sensory function is decreased. And we want to use a RICE therapy: rest, ice compression, and elevation. Now we talked to you about bones, in that in the fracture of bones, although they don't necessarily have an artery per se that's spreading blood, it's highly vascular, and there's a lot of blood that can pour out of these bones when they're fractured. So they will ooze out underneath the skin, causing this type of discoloration and swelling. And so we have edema that's created not only because of the pouring of blood out through the bone end, but because of the injury and trauma that's suffered to the tissue just under and around the fractured site. Fractures can keep the bone in line and without penetrating the skin. That would be a closed fracture, as in the top diagram. And then an open fracture is where the bone ends have penetrated through the skin and now may be exposed. This here is a closed fracture because the skin is still closed. Should the bone have perforated and punctured through and then gone back into the skin, it would still be an open fracture. Here seems to be a large open fracture dislocation of the distal tib fib. It's like the lateral malleolus. So we would try to splint this, cover this in a position of comfort, unless there was some type of vascular or neurological compromise, and we probably try to straighten it if possible to its normal positioning. Here we have another cartoon drawing of an open tib fib fracture of the left lower extremity. We want to cut and expose, monitor the distal circulation pulse, motor, sensory function, and we're going to end up finding that the patients, regardless of what type of injuries, will also have, bruising, pain, swelling, deformity, redness, and may end up having what's called grating or crepitus, where we can hear the bone kind of grating together. Here we have our assessment for musculoskeletal injuries. Again, it's using the National Registry Trauma Assessment Skill Sheet. Again, as far as medical assessment and treatment goes, RICE therapy would be really what we're looking for, and do a good job at splinting and immobilizing those joints and fracture sites. Here's more of a flow diagram, and if you'd like this method, we can use other things to splint up angulated, fractured appendages, limbs, arms, or legs. One we have is a vacuum splint, a traction splint, which is on the left side. You have a spine board and some wrapped up blankets. Then you have some padded splints, and it goes on down to other kind of mechanical ones. Remember, there are improvised splints as well that we can use as far as cardboard, sticks, as long as they're padded. So a traction splint that we just saw, and I'll go back to it real quickly. It has a ankle harness, so this ankle harness will go around it. You see that there's a mechanical wheel that will pull that hook, and it'll pull traction to try to stabilize the muscle from spasming. There's no way that we can put enough mechanical traction to separate the bones and pull the leg back straight. This is just to stabilize the muscle from spasming and causing those jagged bone ends to go and traction splint, though, however, is only used for an isolated closed mid-shaft femur fracture. If it's open, it's not used. If there's other fractures along that same limb, it's not going to be used. And if it's not a mid-shaft femur fracture, let's say if it's a little lower towards the kneecap or higher up involving the hip joint, this traction splint is not going to be utilized. You would also need a backboard because sometimes the extension of the traction splint is far too long to be placed on the gurney just by itself, so we need the backboard to extend a little over so that this traction splint is not dangling over the end of your gurney. An improvised splint here using a pillow. We can use blankets, you can use towels, you can use a lot of different other things to secure it. Here you're using a horseshoe type of a wrap where they are wrapping it around. It's like a stirrup or horseshoe design where they're taking it to wrap around. Here they're using a pelvic binder and SAM splint to stabilize the pelvic girdle. They're going to place this on and then continue to strap that up until it's secure. Now, there are many different types. Please review your notes, go over your lecture notes, go over your PowerPoints, study your book, and the chapter exams.